Thanks very much. We had a little conversation beforehand about the introduction where I said, please, most important thing, keep it short. Other than that, that was the most wonderful introduction I've ever had. It's a pleasure to be back in Ireland. It's a particular pleasure for me because I love the way the Irish speak. It is just the best. And of all the English first language countries I've been, Ireland is the greatest pleasure just to listen to people speak. So I'm going to talk about past, present, and future of evidence-based medicine. So I'm going to describe what I think are three key principles of evidence-based medicine, and I'm going to take a historical approach. So I'm going to introduce you to the people who I think have made the greatest impact. Excuse me. I'm going to talk about its evolution and then challenges for the future. So this might be the most famous guy in the history of evidence-based medicine. How many people recognize his picture? Okay, quite a few. His name is Dave Sackett, and Dave Sackett, I would describe, set the groundwork for evidence-based medicine. He was my mentor and a mentor of a number of subsequent people who've taken leading roles in EBM. And one of the things that he came up with was an early hierarchy of evidence. And that hierarchy of evidence acknowledged that clinical experience is an important source of evidence, as is basic research and observational studies, but that the highest quality of evidence is going to come from randomized trials. That is a hierarchy that was very useful for a long time, was a major contribution, but later in this talk, I'm going to present you with a more sophisticated hierarchy that has replaced it. So, randomized trials are at the top, but some randomized trials are much more trustworthy or informative than others. And we know that failure to conceal randomization, failure to blind, and identifying the 5 groups that we think of, patients, caregivers, data collectors, adjudicators, and data analysts. Failure to blind is going to compromise credibility. If you lose your patients to follow-up, if you fail to analyze as randomized, what's called an intention to treat analysis, and we would certainly argue and have brought forward evidence that stopping trials early for benefit tends to overestimate treatment effects, sometimes very considerably. So, who recognizes this next guy? Okay, a few people recognize Ian Chalmers. Tom was a previous advocate for systematic reviews. Ian is the guy primarily responsible for the Cochrane collaboration. So I'm going to show you slides that if any of you give talks, I very often give a talk that starts off the title, Why Bother About Evidence-Based Medicine? And previously, at the end of that talk, some person would stand up and say, tell me the evidence for evidence-based medicine. I would describe such a person as a smartass. I start off my talk. If any of you do talks like this, remember these slides, happy to share them with you. I never get that question anymore. So what this slide shows is a cumulative meta-analysis. Is there anybody in this room not familiar with such a graph? Okay, everybody's familiar, so I don't have to say much about that. So it's thrombolytic therapy in myocardial infarction. And it's a different meta-analysis than you're used to in that it is cumulative. First trial, 23 patients. Second, not 65, but 42. This is cumulative. And what you can see that up to about 2,000 patients in 7 trials, confidence interval still crosses no effect. 10 patients in 2,500 trials, it's now not crossing no effect. Now, we could ask the question, when was the data in and sufficient that we could stop doing trials? Well, At 6,000, over 6,000 patients, we're now seeing very low p-values, and the lower boundary of the confidence interval is a long way from no effect, suggesting a 25% odds reduction in deaths with thrombolytic therapy. Did this stop people from doing the trials? No, it didn't. Another 40,000 patients were enrolled after the answer is in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why did we have to enroll an additional 40,000 patients? I think a major part of that answer is on the right-hand part of the slide, which says what were experts making recommendations, current recommendations in journals and textbooks, saying as these data accumulated. And it's anywhere from a routine, saying it should be thrombolytic therapy should be routine, specific indications, calling it experimental, or not mentioning it. 2 points. First of all, at certain periods, big discrepancies between the experts. Some saying for sure, some not mentioning it, some saying specific conditions. And it's a decade behind when the evidence was in that finally the experts are agreeing. And if you talk to the people who did these trials, they said, we just have to keep doing trials until finally the experts are persuaded. Not a great outcome. When I was training 45 years ago, I was in a cardiology, doing my cardiology rotation. I went through the coronary care unit, and every patient who came on the door, I started what we called a lidocaine drip, an infusion of lidocaine. Why did I do this? Because we knew that patients with myocardial infarction are at risk for lethal arrhythmias, and we wanted to prevent them. Question: was there ever any randomized trial in support of this practice? Well, if you look here, the point estimates as the data accumulated over 20 years was always on the harm side. Never proved harm, but certainly excluded any benefit. I was giving this drug to my patients, subjecting them to its adverse effects without benefit. Why did I do it? Because that's what my attendings told me to do. And why did they do that? They did that because through this 20 years, most of the experts were recommending in favor of lidocaine, again, you have the divergence or differences in expert recommendations. These are old stories. They go back a long way. They go back to about 1990, and something happened in 1990 that changed the situation. I could tell still some not pleasant stories about experts got wrong, but nothing quite this egregious. So who wants to shout out what happened in 1990 or thereabouts that changed this situation? Answer: systematic reviews. Systematic reviews came in at about that time, and I would contend that if those experts with the thrombolytic therapy or with lidocaine had been presented with systematic reviews summarizing the evidence, it would not have been possible for them to go so wrong in their recommendations. Whoops, going the wrong way again. Sorry. Okay, so the third gentleman to whom I want to introduce you on the left here is Brian Haines, former chair of my department, who has made a number of contributions to evidence-based medicine. One major one is in dissemination of information to clinicians, but another one has been helping with the concept that an ironic principle of evidence-based medicine, evidence itself never tells you what to do. It's evidence in the context of values and preferences. And the gentleman here is P.J. Devereux, who is now leading the world in doing clinical trials in perioperative medicine. But before he got into that, he did another interesting study about which I'm going to tell you. So you are about to participate in this study. So listen carefully, because you're going to have to be holding up your hands in a while. Without treatment, here's the situation. These are patients with atrial fibrillation who are at increased risk of stroke. Consider, without treatment, 100 patients will suffer 12 strokes, 6 major and 6 minor, and 3 serious gastrointestinal bleeds in 2 years. Anticoagulation would decrease strokes in 100 patients to 4, 8 fewer strokes, preventing 4 major strokes, 4 minor strokes. And the question to you is, how many serious gastrointestinal bleeds would you accept in 100 patients and still be willing to administer or use anticoagulation? Now, Dr. Devereux asked a bunch of clinicians and a bunch of patients this. And of course, you have to make sure that people understand the conditions they're talking about. So this is Dr. Devereux's attempt to tell his patients and his clinicians what it would like to have a stroke. So I'll give you a minute to read through that. What it's like to have a major stroke, what it's like to have a minor stroke. Okay? And he had to tell them what it's like to have a gastrointestinal bleed. So this is his description of what it is like to have a gastrointestinal bleed. All right? So, now, the question now is going to be put to you, so I'll repeat the question. Without treatment, 100 patients will suffer 12 strokes, 6 major and 6 minor. Anticoagulation would decrease strokes to 4, 8 fewer strokes, 4 major, 4 minor. How many bleeds would you accept as a patient or a clinician in 100 patients over a year and still be willing to administer or use anticoagulants? Everybody clear on the question? All right? Okay. How many would accept 5 or fewer bleeds? Right? If it's more than 5, no anticoagulation. How many 5 or fewer? A few people. How many 6 to 10? Okay, lots 6 to 10. How many 11 to 15? Still quite a few people. How many 16 to 20? Anybody above 20? A couple of people above 20. So quite an interesting distribution. Most of the time, I give this to clinician audiences, and clinician audiences have a somewhat, well, how many people in this room are clinicians? They see patients, take care of patients. Okay, a minority. So it's a non-clinician audience. So here is what happened when Dr. Devereux asked this. We see that here is for the physicians, here is for the patients. For the physicians, you get a very flat distribution. This particular audience was shifted to the right, I think, from above 6. But some of the people were said 5 or fewer. I was quite surprised, if I looked down correctly, that a couple of the people who did this is the statisticians. Okay, usually it's the clinicians who make that mistake. So, so flat distributions. Look at the patients. 2/3 of the patients are ready to accept 22 bleeds to prevent 8 strokes. You may say, why 22? Odd number. Dr. Devereux was thinking like a clinician when he put together this study. He didn't let them go above 22. They would have had they had the opportunity to do so. So what do we see here? We see 2 things. We see that the values and preferences of the patients are quite different from the values and preferences of the clinicians. The patients are much more stroke averse and much less bleeding averse. So that's the first thing. And clearly from that, if you go to this clinician and you're this sort of patient, it's a problem. Furthermore, although it's much better to use average patient values than average clinician values, The patients differ as well. There's a few patients who are much more bleeding averse the way the clinicians are. What does this tell us? This tells us that to give optimal care, it goes beyond the evidence. It has to consider what we call the values and preferences of the individual to get care right. So, well, we've introduced evidence, we've introduced values and preferences. Evidence is complex. How are clinicians going to make the right decisions? Well, very much worldwide, clinicians are using guidelines, formal structure guidelines, more and more. A good guideline has to judge the quality of the evidence. I presented Dave Sackett's initial characterization of quality of evidence earlier. Question, can we have a more sophisticated way of looking at the evidence? These two gentlemen are Andy Oxman, who took the initiative to start the grade process that I'm going to tell you about. Holger Schoenemann is currently my chair and leading the grade working group currently. How many people in this room have heard of grade? Okay, most people have heard of grade. Maybe some have not. Okay, it's a system to judge our certainty or confidence in estimates of treatment effect, ideally coming from systematic reviews. And, in addition, for guideline panels, a system of moving from evidence to recommendations and judging the strength of recommendations. Now, in the introduction, you already heard something about grade's popularity. It's been taken up and used and endorsed by over 100 organizations worldwide. You've already heard about some of those: World Health Organization, Cochrane Collaboration, NICE in Britain. It has been in the United States leading organizations: American College of Physicians, American Thoracic Society, health technology assessment groups like SBU in Sweden, and electronic textbooks that are now the major sources of where physicians look, things like UpToDate and Dynamed. So big success in terms of dissemination, one reason to pay attention to it. Here is the new, more sophisticated hierarchy of evidence that replaces or is an advance from what Dave Sackett suggested. Randomized trials still start as high-quality evidence in a category that goes from high, moderate, low, and very low, but they don't necessarily stay as high-quality evidence. If trials are unconcealed, unblinded, and lost large numbers of patients to follow up, they become considerably less trustworthy, and you would rate down for risk of bias. If the results are inconsistent across trials and we can't explain the inconsistency, then we have another reason to become less confident. Indirectness refers to, among other things, if the patients are similar to, the patients in the trials were similar to our patients. I work as a specialist in internal medicine in the hospital setting. I found out that if I were in Ireland, I would be a geriatrician, not in America and not in Canada. And why I say that is that more and more my patients are over 80, and in the last decade or so, increasingly over 90. Now, I have randomized trials available to guide my care, but there were very few people over 90 in those randomized trials, and there is a question of their applicability or the directness. The trials of people much younger give me indirect evidence for my treatment of 90-year-olds. So we might lose confidence because of that. Small number of patients, wide confidence intervals, and worries about publication bias. Observational studies, on the other hand, start as low-quality evidence. They could go to very low if they have these problems, but they could also go up. And the main reason for rating up is very large effects. So I'm carrying a cane because of a recent hip replacement. I'm hoping that I will recover fully in due course. We never needed randomized trials of hip replacements because the effects in general, not too many people end up with a cane for very long, and the effects are dramatic. Effects are also dramatic when we give insulin and diabetic ketoacidosis, when we dialyze people with renal failure, when we intubate people dying of respiratory failure, and so on. So they're relatively few and far between, but there's some instances when effects are so dramatic that we have high quality evidence despite the absence of randomized trials. So here is how GRADE suggests summarizing the evidence. This is something called an evidence profile. It's an evidence profile for beta blockers in non-cardiac surgery. The major trial of over 8,000 patients was done by P.J. Devereux, who I introduced you to with his prior study of values and preferences. Myocardial infarction, over 10,000 patients in 9 trials. No problems in each of those 5 reasons for rating down quality. High quality evidence, a 29% relative risk reduction, confidence interval 43 to 14. That's not the most important. Patients are not interested in relative effects. They're actually interested in absolute effects, which in this case is 50 fewer myocardial infarctions in 1,000, confidence interval from 7 to 21. Mortality, over 10,000 patients again. Now we have problems with imprecision. Why? A 23% increase in deaths, but a confidence interval that just overlaps no effect. And if it was a 2% relative risk reduction versus a 55% increase, we would look at the data very differently, and that tells us there's a problem with imprecision. Then you see 5 more deaths in 1,000 if the point estimate is true. Non-fatal strokes, we have, again, the only problem is imprecision. Looks bad. 67% increase in strokes. Confidence interval, however, just touches no effect. So that's the way GRADE suggests presenting the evidence. So what you see there, you have the key outcomes, you have the number of patients in trials, you have the risk of bias, the quality of the evidence and how you got there, and the relative and absolute effects, giving, we hope, clinicians and patients the key information they need. So that's about GRADE and the evidence. What about making recommendations? How can we move from evidence to recommendations? GRADE has 2 classes of recommendations, strong and weak, except that some organizations, like the World Health Organization, doesn't like to make weak recommendations. Instead, they make conditional recommendations, but it means the same thing. So a strong recommendations, the benefits clearly outweigh the downsides, or vice versa. What can make a recommendation go from strong and weak? We've talked about confidence in the estimates, quality of the evidence. Low quality evidence, you're not sure. How can you say with confidence that the benefits outweigh the downsides? Or you can have high quality evidence, but a close balance between the benefits and the downsides may lead to rating down. What do you consider when you do that? The balance between desirable and undesirable, the quality of the evidence, the values and preferences, and although some guideline panels don't like to consider resource allocation, you might. In more recent GRADE work that has culminated in what we call evidence to decision frameworks, we've identified other criteria that might be important, including acceptability, feasibility, and the impact of the intervention on equity. Significant. We like this strong versus weak or conditional dichotomy. Why? Because we think it has direct implications for action. One way that we like to think of strong versus weak recommendations is a strong recommendation, all or almost all fully informed patients would make the choice. A weak recommendation, the choice would vary across fully informed patients. The guideline panels got it right. A majority would choose the recommended course of action, but a minority would not. The implications then, I would bet that any clinicians in this room feel a lot of time pressure. They would like to spend more time with their patients, but they have to ration it. The grade approach gives a way of rationing your time with the patient. A strong recommendation, if the panel has got it right, if you went through a long shared decision-making exercise, everyone or almost everyone would make the same choice. Probably not the best use of time. A weak recommendation means that people will vary in their choices at the end of a shared decision-making exercise, and then it's worth undertaking. How do we make shared decision-making efficient? We need better decision aids. I'm going to talk more about that. Strong recommendation, again, you might not bother if the panel's got it right. Everybody or almost everybody is going to make the same choice. Weak for sure. And finally, we're increasingly interested in quality of care. A strong recommendation is a candidate for a quality of care criteria. A weak, not, because the right thing to do differs across patients. Can't make that a quality of care criteria. So, we've talked about the last bit of the talk with grade is all about guidelines. Well, guidelines can only deal with average values and preferences. So how do we get you saw earlier, individual patients differ in their values and preferences. How do we get it right? This guy, Victor Montori, is doing what I think is the world's best work around that issue. So, at the point of care, we need decision aids to ensure decisions are consistent with individual values and preferences. Victor is an endocrinologist. He deals with lots of patients with diabetes, and here's how he tries to make shared decision-making efficient. Here, he has a patient who is choosing between a number of drugs that you see toward the bottom of the left side of the screen, and he has a number, weight change, low blood sugar, and so on, that the patient can ask about. Of these 6 cards, who wants to suggest what the most popular first card is that the patients choose? Anybody? Okay. Weight and cost are the 2 competing ones that people often suggest, and you have here, and the right answer is weight. Okay, the first one they're likely to ask is its effect on weight. Well, they may then ask about what happens with the daily routine. They may ask about cost, and they may end up asking about all 6, but they almost never do. Victor tells me that sometimes 2, very often 3, occasionally 4, never beyond that. So you don't have to tell them about everything. You tell them about what's most important to them, and that makes it more efficient. Okay, so you've just seen that with this what I think is a brilliant innovation, shared evidence-based decision-making can be done in a feasible amount of time. I think that one takes about 3 minutes. So, the final person I'd like to introduce you to, bottom right, Pierre Van Beek is a Norwegian who has made major advances in terms of guideline methodology that I'm going to tell you about. So years ago, Pierre actually helped us with this. We put out a recommendation with the American College of Chest Physicians. We followed grade. We thought it followed conflict of interest approaches that advanced things. We thought it was great. And it ended up with a PDF like this that Pierre pointed out that to see the evidence you had to either do this or rotate. Not great. So Pierre asked the questions, are these grade guidelines available, useful, and understandable for clinicians? Maybe not. Are they suited for integration into electronic medical records, EBM textbooks, and adaptation? No. Are they sufficiently up to date? No. Within a year or 2 of coming out, lots of the recommendations are out of date. Do they facilitate shared decision-making? No. So, what can we do to get, for clinicians, patients, and guideline developers to advance the dissemination of guidelines appropriately? It turns out, for better or worse, we need magic. Magic, by the way, stands for making grade the irresistible choice. All right. And it involves an electronic platform. This is a crucial part of it. It's called the Magic app. We heard earlier today an analogy to Lego building blocks. Here's your second analogy to Lego building blocks, that the elements here the PICO, the recommendations, a rationale for the recommendations, key information, and so on. And in an electronic platform, the clinician can look to each of these and find out what they need. It facilitates their application. You can pull this up on your smartphone, integration into electronic medical records, adaptation, and decision aids. And so it really potentially advances things a lot. I'm going to talk in the last part here about its use in decision aids. So you have an evolution. This is Pierre again. This is Pierre again. This is Thomas Agaritzis, who spent 3 years with us, has now gone back to his native Switzerland, but he works very closely with Pierre, continues to work very closely with Pierre. And the innovations we have is systematic reviews structured on grade principles, the evolution of decision aids that Victor's work tells you, and this electronic platform, the technology. And you can, putting these together, you can have semi-automated production of decision aids, can be continuously updated, and they can be present for the clinician and patients on electronic platforms like iPads. So, for instance, here is one for rivaroxaban for treatment of deep venous thrombosis, extended treatment. Everybody gets 3 to 6 months of anticoagulation. Then it's a question of whether you had more. And using Victor's approach, we ask the patient first, what aspect of your medication would you like to discuss next? And it was, how am I doing for time? I'm doing okay. Okay, so I'll do a little tangent here then. So we were experimenting with this particular one, and the clinician said, "I have my way of doing it. I tell them first about this, first about that, and the practical consequences are at the end." And I don't tell them about mortality because that's just frightening. I don't want to frighten my patients. Thomas Agaritzis, who was running this, said, okay, no, we just want to see how it is. You can use it in whatever way you want. The clinician, by the time she got to use it, followed the rules, asked the patient what they want to start with. The 2 patients, she did this as part of the pilot, both chose the practical consequences first. That's what they wanted to know about first, and none of them had any trouble with death. And at the end, Thomas did a debrief with the patients, who on both times said, that's the best doctor I've ever had. So, a lot of people, numbers are a problem. The patient ends up finding out about the impact on death, the impact on recurrent VTE, major bleeds, with the point estimates, the confidence intervals, and the certainty. That may be a bit difficult to handle for most people, so we have visual representations of this sort. So the total number there is the people who are going to have recurrences if they do not take anticoagulation. The gold faces, this is in 1,000 people, the gold faces those who will not have a recurrent DVT if, in fact, they use anticoagulants. And finally, we'd like clinicians to understand these principles, so we want dissemination strategies. This is the one on the left, the one on the right is a small version of user's guides. The big one is what some have referred to as the Bible of EBM. You won't be surprised in terms of my showing it to you that I'm the chief editor of this particular thing. And so, in conclusion, the 3 principles of evidence-based healthcare. Some evidence is more trustworthy than others. We need systematic reviews of evidence or we are lost or in the dark. And evidence never tells you what to do. It's always evidence in the context of values and preferences. We need now have a more sophisticated grade-offered hierarchy of evidence from what we had before. And in terms of systematic summaries and guidelines, there's still ongoing user testing to optimize presentations and formats, and ideally we'll have them incorporated into electronic medical records. Values and preferences are crucial. Point-of-care decision aids clinicians need them to optimize decision-making, and they may also help with EBM education, because if you're using this to present the evidence to the patient, you're the clinician, you're learning about the evidence as you do it. And another little final advertisement, which is, if you want to follow what we think is the latest and greatest in evidence-based healthcare, you can follow us on Twitter. Thanks very much.